I hope that's okay with everybody. I'm going to, when I start sharing my slides screen, Emma, I'm not going to be able to see any hands up or anything. So best thing we can do is questions in the chat. Everybody keep on mute if you put your contact details in there, and I'll start presenting and sharing my slides, Emma, and hand over to you. And I haven't introduced myself, I appreciate, so apologies for that to people.
Am I a, do I need to ask you to move on, or do you,
if you
can I move through them?
I'll move through them if you just share.
Okay, no problem. Okay. Welcome everybody. So yes, we've done that first part about sharing who we are. It is really fantastic to see so many different people in and outside of Manchester. Just checking, Helen, is there any housekeeping, or is that on the next slide? So just say it's to be recorded.
Yeah, nothing other than to be recorded. That was my only things, really. That was the only things I was going to mention, was the recording.
Oh yeah, and I think I know probably a good few of you on the call, but just to introduce myself, I'm Emma Vardy. I'm a consultant geriatrician based in Salford, but I also have roles in Salford as part of the Northern Care Alliance, and also working with Helen in Greater Manchester on delirium pathways and various resources, and also involved with the British Geriatric Society. So nice to see you all. And yes, do put any sort of questions as they come up in the chat. So if we can move on to the next slide, Helen. So this is our agenda, and I know we have timings, so I'm just going to rely on you, Helen, to prompt me to move on. But I think probably our slide timings, you know, will sort of be about right, won't they? But if there's sort of, we'll let you know, probably pop questions in the chat, and then we'll, depending on what stage we're at in terms of timings, take some questions at the end of each speaker, if that's okay. Is that right, Helen?
It is. So the plan is that we're going to run through the 3 presenters, then do a Q&A for about 15-20 minutes, then have a break for everybody to stretch their legs, get a drink, comfort break, and then 3 speakers and then a Q&A. So yeah.
Brilliant. So we'll move on to what is delirium, why is it so important? And many of you will know much of this, but it's just really to sort of set the scene and just fill in any gaps that are in anyone's knowledge. So it's acute, it's new in onset, it develops over hours or days. So in that sense, it is different to dementia. Many people recover, some don't fully recover. The duration of it can vary, but unfortunately it is linked with a high mortality rate. Some of the features are that impairment of attention, so not being able to focus, concentrate, that either sort of hyper alert state, hyperactive delirium where somebody's like agitated, or that hyperactive delirium, hypo alert, where somebody might be more drowsy or just sort of more quiet and introverted. Other ways that it can present are changes in behaviour, so that can include hallucinations, being paranoid. Also, other sort of features may include, it can be mistaken sometimes for depression. It can be very distressing for the individual experiencing it and for those who are related to them or caring for them, or those looking after them in various settings. So there is the hyperactive type and that hypoactive type. The hypoactive type tends to be sort of less well recognised, and hyperactive type tends to have poorer outcomes, maybe because it's more easily overlooked, and sometimes people can fluctuate between the two. Delirium can vary in duration. It can go from a few days to several weeks, and in around 20% of cases it can persist for weeks, and sometimes it can also either prompt a decline in somebody's dementia, or it can be the kind of the first step in a journey towards developing more chronic cognitive symptoms. And there was a reference to the Zine, Scottish Zine guidelines, which are well worth a read if you haven't looked at them. It's associated with a high mortality rate, so 1 in 5 people will be dead within a month who experience delirium. There's also increased length of stay, increased readmission rates. It's also linked with the person's mobility might be affected when they have a delirium, and the person may not get back to their previous level of function, and it's linked with higher levels of institutionalization, so people may not get back to their own homes. And as mentioned before, there's that risk of deteriorating cognition when somebody has an existing diagnosis of dementia, but equally it can increase the risk of developing a dementia in the future. Around a third of it is preventable. That's from hospital-based studies. And incidence of delirium from research studies is around 1 in 8 hospital inpatients. It can be found if you look for it in most areas. It's also prevalent in other settings such as care home residents and also in palliative.
Oh, I think we might have lost a connection there with Emma. I'll move on. I'm sure Emma will join us again in a minute. Hopefully, Emma, you'll come back in. So I'm just going to introduce myself now. My name's Helen Pratt. I'm a project manager with Dementia United, and Dementia United is Greater Manchester's integrated care programme for dementia, their quality improvement programme. So we work across all settings: primary care, mental health, adult social care, acute hospitals, with a wide range of professionals, including people with lived experience. And our aim is to make Greater Manchester the best place to live if you're living with dementia. And why I say all of this is because the delirium programme of work falls within the programme of work that is Dementia United, and a link to us, our work is on there, so I'll share these slides with you afterwards. Those of you that have just joined us, we will be taking questions at the end of the presentation, so put any questions in the chat by all means. And we are recording the session, and we will be sharing the link to this recording because we'll add it to our YouTube channel. So anybody that's just joined, please put your name, details, location and your email address, and we'll make sure that you get these slides and all other resources. We're going to send out some delirium training resources as well for you from today. So the Greater Manchester programme of work in around delirium started with some free World Delirium Awareness Day events that we hosted in 2018, 2019, and then just before the pandemic in 2020. So we were able to use those events to harness a great and build on a great community of practice. So as I said, with lots of different people engaged, from mental health, care providers, care homes, allied health professionals, all came together to try and look at what do we want to improve in Greater Manchester. And the programme from the outset has been focusing on prevention, but also how do we ensure the early detection of delirium, and also offer a systematic approach to that assessment in order to establish causes of delirium and the management of delirium. And our goals when we set up the programme were to try and keep people with delirium safely managed in their own home or in their own care setting, try and reduce those unnecessary hospital admissions. If somebody does go into hospital, or if somebody does develop delirium and goes into hospital with delirium, we want to improve the prognosis, so reduce that length of stay, improve the outcomes for that person, and ensure that we're able to detect in a standardised way across Greater Manchester. And we came up with an overarching pathway, which is on the slide to your right, which we've applied across all settings. So I can share the details of that pathway with you all. So in terms of what we've been able to do since then, we developed 2 toolkits, a hospital toolkit and a community toolkit. And in early in 2020, we were asked, as the pandemic started, to escalate having the community toolkit available to teams working in the community. And in particular, the offer went out through Primary Care Board in Greater Manchester to see if there were any teams willing to come forward and use the toolkit to enable them to start detecting early, as I've said, standardise that assessment and manage somebody, hopefully without them going into hospital. 5 localities came forward with an interest, mostly the urgent care teams, the crisis teams. However, there was one primary care network and one intermediate care service that came forward as part of that pilot. And the pilot really was to try and understand what we needed to implement the toolkit, and also could it deliver on the benefits and goals, keeping people at home. And improving the prognosis for people. Great results. So we had 6 months of intensive support for those pilot teams, and they were able to keep 70% of the people with delirium safely managed in their own home. As well as people being managed safely at home, families reported a real positive impact on all the resources that were available. So the team going out, having a standardised approach, but also the delirium leaflet. So the ask of Greater Manchester from that, as we presented to the GP Primary Care Board across Greater Manchester, was to try and roll out the toolkit as we are doing, and that's why we're hosting this webinar today, which is fabulous. We've been able to publish our pilot, so the link's in the slide, which I'll share, and we're currently in publication, awaiting for our qualitative evaluation of that pilot too, which will be coming out shortly. In terms of the resources that we've got, as I've mentioned, there's 2 toolkits, but we've also got a delirium leaflet, which has been translated into 10 languages. So it's available as a shorter version in 10 languages, as a film, an audio resource and a written resource. We've got quite a lot of training resources. We've got Emma's done a delirium webinar for the North West Ambulance Service, as well as a GP podcast. We've got lots of conversations with the pilot team, so you can hear from them themselves, which we've recorded, and other GP resources, and lots of other things that we can share with you, which will be fabulous if you can use them and take them forward. In terms of the wider GM delirium programme, so we're taking forward as much as we can that wider engagement, working with different groups across Greater Manchester, hospital delirium group, a community delirium group. We're harnessing lived experience. We've been working with colleagues in North West Ambulance Service and moving a bit more wider than just within Greater Manchester and the North West. We've been linking in with other areas, sharing the resource, working with NICE on a case study as well, and also as part of the European Delirium Association as well. So that's our Greater Manchester programme. Emma, are you able to come back in now? I'm hoping to hand back to you, if that's all right.
Yes, I'm really sorry about that. I'll explain later. So yes, luckily I got to the end of my slides just before, didn't I?
You did.
So I've just looked, there's 60 people here, which is absolutely fantastic.
Oh, I haven't been able to check, so thank you. Just a quick reminder then, everybody put your email in the chat, because we may not know how you've come to this session, and it's wonderful that you have. So we want to make sure that everything we're talking about today we can share with you. So sorry, Emma, I'll stop interrupting you.
That's okay. And the bit from the introduction that I didn't include was there's an evaluation form, which if we haven't sent it out already, we will, or we'll put in the chat, but to make sure that you feed back to us for how we can make it better for any future events. So the next session is well, the first of 3 best practice examples from across Greater Manchester. And I'll introduce each person as they go. So Jane Etchers from Stockport is going to talk about their implementation of a community delirium pathway and toolkit. And all I know is it's fantastic and it's award-winning. So I'm going to let Jane introduce herself and take it away.
Hello, Jane, are you with us?
Yeah, I'm with us. Hi, everybody. Thank you for this opportunity. So the Stockport Community Delirium Pathway is on the back of the inspirational work by Helen and Emma. So as we've said, we took part in the initial pilot, and the Community Delirium Pathway is a person-centred approach to the early detection, rapid assessment and successful treatment of delirium in the community setting. Okay, so what we did, well, what we realised is we had to proactively look at identifying delirium in the deteriorating patient. We want to provide a rapid clinical assessment and devise a treatment plan with the patient and the carers in order to keep the patient, this vulnerable patient, at home. What we did was we trained all staff in the early identification of delirium. That's the hypo and the hyper symptoms that Emma alluded to earlier. We developed a pathway, as in identification of the possible delirium, moving on to narrowing it down to the cause and the management plan. We did the initial pilot, as Helen said earlier, with the Victoria district nurses. So even though it was a small pilot, only of 7 patients, it was really successful and easy to implement. We then decided we needed something more robust. So it was, we used the GM documents and the patient leaflets as a baseline, but we formalised the pathway, so we standardised it across Stockport. We looked at staff and patient experience of using the delirium pathway, but also of patients who were involved in the pathway. And then we gathered data, evaluated, shared the project, and then we've been able to roll it out across the community in Stockport. So the new way of thinking is patients in the community who are suspected of delirium, they receive an assessment in their own home, and that's because delirium is classed as a medical emergency, which requires a 2-hour response. What we ask is that primary care clinician does the news too. They do urgent delirium screening bloods, and they use the 480 tool to look at the delirium screen. If the patients do screening, then they're referred to my crisis response team for a rapid clinical assessment, and 98.9% of the patients on our caseload receive the assessment within 2 hours. We then take it a step further and we use the Pinch Me acronym to look at the cause. So is it physical? Is it nutrition? Is it environment? Constipation? We really narrow down to see what the cause is. We also review the bloods and we do a functional risk assessment. Once we've got all that information together, we then co-produce a community management plan with the patient and the carers to look at safely keeping the patient at home. So we look at the treatment. Is it antibiotics for a UTI, or is it medication optimization if there's some pharmacology involved? It truly is an MDT approach. We have access to the mental health liaison team, which is quite unique really, because one of those team members comes to our huddle every morning, and we can look at a very bespoke plan for the patients. Obviously, onward referrals once they're stabilised. Outcomes, the majority of patients are kept at home. We do have access to step up ring-fenced beds, which are overseen by the mental health liaison team, which is quite unique. But obviously there is a need for patients to go to hospital, so we will obviously escalate and call an ambulance if an ED admission is required. So what's changed? Before, when we spoke to the clinicians, so this was pre the delirium pathway, the primary assessment was the community health nurse, NWAS. What the clinician said was, in 100% of cases, they dialed an ambulance because they didn't know what the other options were and felt the only option was for that acute clinical assessment to be taking place in ED. 100% of the patients ambulance called, they went to ED, and in 21 to 22, if there was 100% of patients that went to ED, 98.1% of patients were admitted, and as Emma said earlier, the length of stays increased, deconditioning, hospital health acquired infections can be transmitted. It's just not the right place for patients to be. So now with the delirium pathway, we've got a very bespoke pathway for these patients. So we provide the rapid assessment within 2 hours. Within our team, we've got AMPs, ACPs, sorry, we've got nurses, therapists, social workers, support workers, and they're all part of that 2-hour assessment. We've devised the community management plan, which with immediate treatment and support. And then the outcome, 88% of the patients who were on this pathway were able to be kept safely at home. So we avoided an acute admission and the side effects and the problems that can occur with patients who are admitted to hospital. Next slide, please, Helen.
Has it come up?
Not yet.
Oh,
It has on my screen.
that's on mine as well.
Oh, thank you, Helen.
Jane, sorry. It's okay, don't worry, Jane.
Okay.
It's fine.
So the feedback from the patient and carers was obviously really important, because it wasn't just about us putting a pathway in place and ticking a box. We needed to know what we were doing was right for the patient and right for the carers. So when we spoke to patients and we used clinical audit tool, 60% of patients felt they were sad before the crisis response came to assess them. 83% of patients were happy with the plan to keep them at home. And again, you can see the question that we asked there. And when we asked the patients, can you tell us how you felt about the communication while the team were involved? So that was using the delirium leaflets from Dementia United. 100% of patients felt they were happy with the communication, which we felt was really reassuring. We also asked about privacy, dignity and respect, and 90% of patients were happy with how they were treated. 100% of patients said that this pathway supported a avoidable hospital admission, and all the patients felt it was a positive experience and had a positive effect on their lives because of that avoided hospital admission. So patients felt safe, supported, relieved and happy, as opposed to frightened, misunderstood, annoyed, uncomfortable and confused, which we felt was just really positive for patients who were involved in the pathway, for them to have a voice in how this had such a positive impact. Also really informative. So 100% of staff felt that the pathway was clear to use. 100% of staff using the pathway said the pathway increased their confidence in managing patients with delirium in their own homes significantly. And 100% of referrers said that the pathway prevented a hospital admission because of its clarity and the specific guidance involved. 100% of staff that were questioned, and these were district nurses, discharged to assess nurses, community ACPs and support staff, they felt that this pathway supported keeping patients safely at home. And 100% of staff said preventing hospital admission is the best outcome for patients experiencing delirium with their carers. And that says it all, really. It's about patient experience and not just about processes. Okay, so the spread, August to March, we did the pilot, as Helen said. March to December, we rolled it out across the Stockport boroughs. And from March 21, we've shared the pathways as a learning experience with GM colleagues and other partners and stakeholders in Stockport. And I'm really proud, on the back of this work, I've been appointed as a committee member on the NICE committee tasked with reviewing the delirium guidelines. So from small oaks grow great oak trees, and can't thank Helen and Emma enough for their support. So thank you, everybody.
That's fantastic. Yeah, thank you, Jane. We are a little bit ahead of time, so if anybody has a question for Jane, then I think I'll be able to see you if you pop your hand up.
I don't know whether I finished early. Helen, was there one more slide, or was that the titles?
Oh, one more.
So that's just a summary, really, of what the patients and the relatives said. And yes, thank you, as Emma said.
Princess Ozoya, it's just popped hand up. Do you want to ask your question?
Hello, thank you, everyone. And Jane, I wanted to clarify, did you say there were fence-off beds for should the delirium client have to go in to hospital, say they were assessed as not suitable to be managed at home?
Yeah, we're very lucky in Stockport. We have access to a community psychiatric unit which has a specific ward for elderly patients. So if we've got a concern about a patient and we can't provide that 24-hour support, then we can admit to that unit, and it's facilitated by our mental health older people's team.
Wow, that's great. That's just wonderful. Thank you.
I'm just seeing the next speaker is Anam Ahmed. I just want to see, Anam, are you on this call? Because I can't see her name listed unless she's under a different person. Shout out if you're here. Because I'm just wondering whether to go to the third speaker just in case Anam's running a little bit late. Will that mess things up majorly, Helen?
It certainly won't mess things up for me, but you would need to have, is Jackie joined us?
Oh, Jackie has joined us. I've seen Jackie on here, so I'm just wondering if we can go. Hello, Jackie. So in that case, I can present, though, if Anam doesn't manage to join us. It's just if she was planning. I know she's a busy junior doctor. Still not got any. Oh no, that's another message from another meeting. So yes, I'm going to introduce Jackie and Helen's piece of work. So Jackie Widowson is
speak through. Sorry, keep going.
colleague who works with Oldham Libraries and connected up through Dementia United and reached out about was there something that the library service could help with, and Jackie introduced myself and Helen to the idea of zines, and we had a Greater Manchester zine workshop, and I will let Jackie explain all. So go ahead, Jackie.
So I think it's me coming in first, Emma, and then I'll hand to Jackie. That's okay, thank you. So I know I ran through the Greater Manchester Delirium programme at speed earlier on, but one of the things we wanted to focus on now was the value of harnessing lived experience and co-production. And that's been at the heart of our programme, in Dementia United, but also in the Delirium programme of work. We've been very fortunate to have people living with dementia, a dementia carers expert reference group, a South Asian carers group, and the Greater Manchester Older People's Health Network, who all reviewed our delirium leaflet when we were devising it. And we wanted, as a result of all of that, really, and that great engagement, we were asked to translate the leaflet into 10 languages, to not just have a written leaflet, but to have an audio resource, to start collecting people's lived experience. So the links here will take you to some of those lived experience examples. And there's a lovely picture there of Liz and Mike, who did a great film with Health Innovation Manchester as part of the Greater Manchester Delirium programme of work. And we've also got an audio account. And if you haven't heard it already, it's absolutely brilliant, by John O'Doherty, who's one of our Dementia Lived Experience Governance Strategic Board Governance Board members. And his account of his delirium, very harrowing, but really powerful to hear. So we'd already been connecting up with Jackie in Oldham, and I was having a conversation about what other ways can we be harnessing that lived experience other than obviously having a film and John's account. And it was Jackie that came up with the idea of a zine. And Emma and I are both book group members and thought, oh, this sounds very interesting. So that's where we sort of took ourselves into a conversation about how could we enable people with lived experience to provide their words in different formats to the ones that we already had. So great partnership working with Oldham Libraries. And I'm now going to hand over to Jackie.
So we've said the word zine a few times now, and some of you may be familiar, but many of you may be thinking, okay, what is a zine? So zines have a long, illustrious history of giving voice to the disenfranchised. It's quite strongly associated with things like the civil rights movement and other forms of social activism, because it's a self-published 8-page pamphlet that can be sort of folded out of one piece. And it's a mixed media format as well. So you're talking about something where the author doesn't have to be a person of many words, or doesn't have to be a high level artist, because it can be created in any sort of eye-catching way that you can think of, either with powerful words, full sentences, collage, art, or what have you. So it really allows it to be a very versatile format that plays to the strengths of the participant, whatever speaks to them, however they are most confident communicating. It's also something that can be easily reproduced. So it's, again, a little leaflet size. So if you're spreading the word about something in a public awareness campaign, for example, it becomes something that you can reproduce in many ways quite easily if you want to pass it around. And I think that's it. Yep. I was going to say a next slide moment. Thank you, Helen. So Oldham Libraries, why were we at that table in the first place? That's another question that might be popping into some of your heads, because of course we're not healthcare professionals or anything like that. And so it might not be obvious to some people why the libraries, and I should say more honestly, we're actually heritage libraries and arts, so it's slightly bigger than just libraries, but why we were in the mix. So we were there because the libraries have a very varied programme of health offer and public awareness campaign work that exists because libraries in the UK currently operate something called the Universal Health Offer. So again, I'm going to make the assumption, hopefully correctly, that some people in the call don't know what that is. About 10 years ago, there was something called the CCART report, which identified that the UK library services, 151 different library authorities, all doing fabulous stuff, but all very much going off in different directions. And that made it incredibly difficult for users to know what they were going to get when they came into a library, and for us to have those economies of scales and the continuity and public facing messaging that's continuous across the country. And so that lots and lots of pieces of work came out of that report. It was very, very catalytic within our sector. It was brilliant. But one of the things that happened is that the Society of Chief Librarians became something known as Libraries Connected, and they created universal offers. And the universal offers are something that your libraries up and down the country are working to. This is absolutely fabulous when it comes to things like the work Helen and I were doing together, because it facilitates partnerships, because it means that we are working to common goals and we are talking common languages. And it means that things like the work we've done in Oldham are replicable in other locations as well. So we also felt that as a cultural engagement, a cultural offer, we were well placed to add a cultural spin onto the public engagement and public awareness raising aspects of this public health campaign, and that we could also integrate it into other pieces of work that we were doing. I could go on there a little bit longer, I must admit, but we've only got a couple of minutes. So next slide. Thank you, Helen. Sorry, I'm not following my bullet points too diligently, which makes it harder for Helen to do her job. Sorry. Right. So a delirium Zine workshop specifically for us, what did that involve? Obviously, we needed to have that mixed media resources in the room ready for people to participate, including your magazine and colour paper and all of that jazz. We opted to go for a paid professional a professional facilitator. Zine workshops are something that we as a service do offer in-house. It is something that anyone can facilitate in-house if they have the means, but we really wanted to make sure we had a high quality environment. So we paid an external facilitator who we were directed to by the Northwest Zines Library. In order to make sure that everyone was comfortable and relaxed, we provided refreshments, and importantly, we created a prompt booklet. If you present someone with a blank page and say, express your experiences into this page, it's paralyzing. It's very, very hard to know how to start, how to write the first words, how to put the first image down, or what to do. So one of the recommendations when you're facilitating a Zine workshop is to have little prompts that help tease out some of those thoughts, get those creative juices flowing. So we created our prompts based on building on all the work that Helen and her team had already been doing, gathering the lived experiences. So we were taking those sparks of inspiration and teasing them out further to see where that took us. The other important thing was to remember that not everyone attending would necessarily find getting to Oldham Library a particularly easy task. So we did put on transport. And of course, we wanted those zines. So the experience itself, we were hoping it would have emotional psychological benefits for the participants, but we also wanted to use it for this public awareness raising outreach aspect. So it was incredibly important. We asked every participant to mark their zine with a CC, a Creative Commons license, which means that we are at liberty to share the experience with wider audiences. So what were some of the key findings and learnings from the day for us? We were absolutely delighted to find that our participants even surprised themselves with how much they were able to participate in the day. People who went in saying, oh, I'll come along, I'll give it a go, but actually weren't expecting to be able to do very much, did find the format very conducive to getting creative and expressing those thoughts and ideas. 100% of our attendees said they were able to participate. At first, we weren't sure whether to include the perspective of healthcare professionals and families, or whether to focus in just on the lived experience of the person who has had the delirium episode. But actually, it is our belief that we got a much more rich and interesting product and workshop from including that whole systems approach, that wraparound approach of including both those with the direct lived experience of delirium, but also those supporting it either professionally or as a family member, as an emotional support system. Yes, and of course, in order to build the audience that we wanted to attend the workshop, it was important to work, again, build on the work that Helen and Laura have been doing, creating those networks of people with lived experience in order to find them. We took a short presentation of the groundwork to this piece to one of the GM conferences. Helen, what was it called?
Oh, it was the event on the 6th of June. If anybody was attending it, it was Living Well with Dementia in Greater Manchester. Join us. We need each other event. So Jackie did a fabulous presentation at that event as well. So yeah, thank you.
So it was just, it's a nice example. Thank you, Helen. Apologies for forgetting exactly, but it was a nice example of how by networking this piece of work into everything else that was going on, it's the way to connect with the right audiences for it. And the resultant zines that we have created, we are posting those as an ebook on the GM Libraries ebook platform, BorrowBox. So it will be available to download there with any library card, which of course library cards are free and downloading off the ebook platform is free. So in other words, that constitutes a very wide circulation across the GM for people able to access that, both to use as advocacy for raising awareness around living with delirium, and for people interested in how to run a Z workshop of this type.
Fantastic.
I think I've got one more slide just to end on. Sorry, thank you. If I may indulge, and that's just these beautiful little sound bites from participants. I was very keen to share them because I think as the whole experience was about how when you take the first-hand voice of someone who has lived through an experience, that it's more powerful. And so here's some first-hand voices of people who enjoyed our Zine workshop. And you'll see from certain quotes in there about how people did find it effective. There was a personal sense of well-being gotten derived from it. It was a therapeutic experience, and it really got people talking, and the awareness of the underlying need to use creative formats like this to get people talking about these difficult topics. Thank you very much, everyone.
Thanks, Jackie. And there is a question in the chat, but if it's okay, I'm going to defer that to the end because I'm just being a really rubbish chair and it's time for questions after these three presentations. So Anna has now joined us. So if you can whiz back to her session. So I'm going to introduce It's now Dr. Anna Mad, isn't it? And you were a medical student who selected one of the student options to work with me, and we developed this project, didn't we? And you're now a qualified doctor since you did this piece of work. So Anna is going to talk about the piece of work she did looking at the 480 delirium assessment in non-English speaking patients at Salford. Thanks, Anna.
Hi, I'm really sorry. I can't, it says that my camera is not on, but I'm trying to turn it on. Is it on?
It isn't. Oh, no, it doesn't have no, it's not on, and it doesn't have like a camera off, but we can hear you, and all you need to do as well is just ask Helen to move the slides on. So it's not perfect, but I think it'll still work.
Okay, sorry, thank you. Hi, thank you for the introduction, Emma. So yeah, as Emma mentioned, in May, when I was a medical student, I worked with Dr. Vardy to do this study, which is on the accuracy of the 480 in non-English speaking patients. And today I'm just hoping to tell you a little bit about that. If you can just go on to the next slide, Helen, thanks. Okay, so there were two main aims to this study. So firstly, to assess the accuracy in patients who don't speak English. So this study was based at Salford Royal Hospital, where it's in the guidelines that anyone over the age of 65, non-elective admissions should have the 480 completed on admission. And we just wanted to see if that's happening and how accurate it is in patients that don't speak English. And the second part of this was also to check if translators, interpreters were used during these assessments, and if they were, whether they were lay interpreters or formal interpreters, with lay interpreters being friends, family, and staff members who aren't formally trained to be interpreters. Thank you. Okay, so a little bit about why this is important is a little bit about non-English speaking patients. So patients who don't speak English make up a significant number of patients in the NHS. It's obviously a subjective nature, how well people speak English and how well they understand English, but some indication to this is the 2011 census, which showed that around 2% of people in the UK said that they don't speak English well or at all. Obviously, things not being able to speak English can pose language barriers that can make room for misunderstanding and miscommunication. And in NICE guidelines, it does say that interpreters should be offered and given. And also GMC does state, so the General Medical Council states that all efforts should be made for effective communication. And that obviously means that if patients can't speak English or can't understand English, then we should make all efforts to give them an interpreter and someone that they feel comfortable with. When I was conducting the literature review for this study, I also noticed that many studies that looked at delirium and the accuracy of the 480 excluded patients that didn't speak English. So there was a little gap in the literature as well. Thank you, Helen. So going more onto the study and what it involved, so this was a retrospective study where we looked at all non-English speaking patients who attended A&E at Salford Royal over the age of 65 in a 5-month period. And this then generated a list, which I went through, and I ensured that the patients were non-English speaking, and this came to 76 patients in that time frame. I then used the admission documents to find details about the 480, if it had been conducted, and then more information such as why the patient had to come in, what they scored in the 480, what language they spoke, and if an interpreter was used. And obviously this spreadsheet was anonymized as well. Yeah, if we could just move on to the next one, Helen. Thank you. Okay, so the first part of the results was looking at the first aim. So to begin with, 16 different languages were spoken, with the most prevalent being Urdu, then Polish, Arabic, and there were many other languages that were also spoken. In terms of how many patients had the 480 completed, only 22 patients out of the 76 patients had the 480 completed, which makes up about 29%. A similar study was conducted looking at all patients over the age of 65 and how many of them had their 480 conducted, and that showed 42%. So in the non-English speaking patients, there was significantly lower amount of authority assessments conducted, and that is shown by figure 2. And secondly, there was a variety of scores, however, majority, 50% got scored 0. Okay, and then in terms of our second aim, so looking specifically at if interpreters were used and whether they were lay or formal interpreters. So of the 22 patients who did have their 4OT completed, 5 didn't have an interpreter at all. Obviously, language barriers can be disorientating in themselves. So that is interesting to see that 5 didn't have any interpreters. And then the 17 who did have interpreters, only 4 were formal interpreters. With lay interpreters, there have been studies conducted which show about a 22% margin error rate for lay interpreters, but also it does mean that many times the lay interpreters were people that were friends or family with the patient, and if we can actually supply patients with interpreters, it means that the family or the friends can be there to support the patient instead of having to have this second role of also being an interpreter, and it can hopefully ease some anxiety. Okay, so moving on to the conclusion and some recommendations. So firstly, the first conclusion is that there was less than a third of cases the 480 was completed. So there are easy things we can do to try and increase awareness of completing the 480, such as putting up posters, especially in the clinical area. Obviously, there are time pressures and time-sensitive matters, which does make it a little bit hard to do the 480 sometimes, but by putting up posters can just increase awareness. And secondly, in terms of using interpreters, so the 480 has been interpreted into about 8 other languages, including Italian and German. Unfortunately, it has not yet been translated and validated into Urdu or Polish or Arabic, which were our most prevalent languages, but it has still been translated into some languages, which is a good step forward, because it means that interpreters can use that to follow the template of the 480 instead of having to. Yes, and those 480s have been validated as well in the other languages. Another thing is just ensure that interpreters are present or at least offered to the patient, so the patient can make that judgment themselves if they want the interpreter or not, but at least making sure that they're aware that that is an option for them. And that brings me to the end of this presentation.
Thank you so much, Anna.
Thank you.
And I'm just going to say that Anna's work has been accepted. She's going to be presenting it in Milan. We're going to Milan for the European Delirium Association in a few weeks' time. So it's one of a few posters that we've submitted. One of the other ones is around the community delirium work. So it's brilliant. So we have some time for some questions. And there's one in the chat for you, Jackie, from Rafia Malu. Rafia, do you want to ask your question? If not, I'll fill in. The question, what? Oh, yeah. You there, Rafia?
Yeah, hiya.
Yeah,
I was wondering if there is anything like your Zine workshops available in Bolton. I actually work with a lot of elderly people with dementia, Alzheimer's, and so there isn't much available where I am at the moment.
Yeah, so the Zine workshop format, obviously that's not prescribed. How different library services respond to the remit to engage their audiences is going to vary still between library authorities. I'm not aware of Bolton running zines as such. However, one of the aims behind the project was the fact that we are very happy to share the format that we've created, and we would strongly encourage people to also sort of attempt to replicate the partnership facet. So if you approach your local library authority and say, I have a group of people who would I know would enjoy to attend a Zine workshop, and I've got this resource that I've got access to because I heard about it, at this webinar. So like I say, please do let us know if you want a copy of the prompts. Then there's a good chance that they will connect you with their health offer lead and be able to explore whether they have capacity to offer a free space, maybe even a member of staff to help in the facilitation side of it. That again is going to be slightly variable. You have to find out what capacity you've got from within your own teams and networks and what capacity they've got within theirs. But we definitely would encourage you not necessarily to look for a completed product that's the same, but to potentially open conversations about whether they have got the space, what they do have capacity to host with you, in the hopes that they might be able to offer something very similar to what Helen and I were able to achieve together.
Yeah.
Oh, fantastic.
And we are going to be publishing. It's going to be available, so it's in Dropbox, and presumably we might have a link on the Dementia United website, would we, Helen?
We will do.
Yeah.
When
Yeah.
we're able to publish, we will share the
Yeah.
zine that we've created, and it's got the evaluation and the prompts in it. And the other thing we're doing is that we're going to be hosting a zine workshop as part of the European Delirium Association conference next year. Emma, is that right?
Yeah. Yes, and it's still an exciting destination. It's Birmingham, but I'm afraid
Not Milan.
Well, it's not Milan, no. But it will enable more people from the UK to go, which will be great. And yeah, we're just working out how to engage colleagues over in Birmingham. If there's any other questions, pop them in the chat or pop your hand up. I'm just as Princess, I'm assuming yours is a legacy hand because it hasn't gone down. So, but if you did have a question,
Right, I'll take it down now.
Okay. I'm going to ask Anam a question, which was, this is the using formal interpreters. We don't see much of it happening in the NHS, and I've sort of become increasingly aware of the importance of a formal interpreter because of that, the element that's lost in translation when you don't have a formal medical interpreter. What do you think the barriers are around that? Yeah, in your experience, why do you think people don't get formal interpreters?
Thank you for the question, Emma. So I've now started working as a doctor, as you mentioned, and I'm working in a psychiatry job. Many of our patients aren't English speaking here either. I'm actually working in Birmingham. And I have noticed myself, I think one of the biggest barriers, one of the biggest reasons is definitely that it just takes more time. It takes a bit more time to organize. It's a bit harder to always ensure that an interpreter is present. Sometimes it's hard enough just trying to get the healthcare professional and the patient to meet. So then adding in another person who also needs to be present, that's definitely one reason why why it's so hard to get an interpreter. There's other reasons too, such as from the patient side. For example, things like maybe the patient feeling like they might not be entirely confidential or feeling uncomfortable to speak to someone else. But I think things like that come down to explaining to the patient that we're all healthcare professionals and we're all going to be confidential in our manner. I'm going to make sure that the conversation stays between who it needs to stay between. And just by reassuring the patient like that, I think it really would help patients. And I think just by explaining to patients that they are entitled to an interpreter if they need one, and then just going to the necessary lengths to get them an interpreter is really helpful. And myself, I've used interpreting services in this job now, and it really is a lot simpler than it seems, and it really does make a difference to the patient when you offer them an interpreter and you actually follow through with that interpreter.
Yeah, I'm going to ask you one more question before I come to Jane. Did you get a
Yes,
feel? Did you feel that you got Anam? Did you get a feel that? Did you get a feel for the accuracy of the 480, like that sort of significant number that scored 0? Do you think people might have been kind of either misdiagnosed as delirium or have their delirium missed? Did you get a feel when you were looking through patient records?
Yeah, I definitely did, because for some patients, well, for example, there was 5 patients that didn't have an interpreter. The 480 changed in how much information was written when I was reading through the admission details. So for some patients, there was a lot of information, and for some patients, there really wasn't that much information. And it just calls into question how much you can get from a patient when you're not using an interpreter. but also if you're using someone that's their family or friend, you don't know how much they're telling you then, and how much you can go from what the patient's actually saying and what their family or friends saying.
Yeah. Thanks, Anna. Oh, Jane, have you got a question for your fellow speaker before I ask you a question?
I have actually. Just from a personal point of view and learning disabilities, I think that's a downfall of the 4AT because, you know, my daughter couldn't do the months backwards, and she would score on the 4AT. So it'd be interesting to look at. We've looked at alternative languages. Is there something for learning disabilities that we could look at?
It's funny you should mention that, Jane, because I have a physician associate looking at exactly that at the moment in Salford. But interestingly, as a result of the work that Anam's done and the questions it raised for me, I'm pretty sure we'll probably find similarities with learning disabilities as well. I added sections to our hospital delirium guideline on learning disabilities and non-English speaking, making reference to things like the Royal College of Physicians, I can't remember what it's called. It's something like a toolkit for people with learning disabilities. So yeah, we can. It's just going through a few final approvals, but we can share that with you because I think it's a really good point. So I'm going to ask you a question, and then somebody's got the hand up, so I'll work out who it is in just a second. But I'm just going to ask you the question, Jane. That's absolutely phenomenal that it went from 100% people with delirium being transported to hospital to 80% staying at home. Have you got like any sort of, did you do any sort of sums and calculations about how many sort of bed days that you'd avoided, and was it felt at kind of a hospital admission and flow level at all?
Yes, I can send the information to you. On average, patients with delirium, their length of stay is 5.5 days, but patients can go, you know, above and beyond the 21 days. So we did a benefits analysis looking at the cost savings, and the cost savings included ambulance transfer, ED attendance, bed day, and then patient transfer home. So yeah, there was significant savings.
Fantastic. Melanie Worsley, you put your hand up. Do you want to go ahead with your question?
Yeah, thank you. It was just to ask, you know, the assessment tool that you're talking about, will that be sort of available for us to have a look at? I'm just quite interested in what sort of questions are asked of the patients.
I'm really sorry,
Do you want me to come in on that point?
Yes, go ahead.
I think it's all right. So the 4AT is a very simple sort of, it asks 4 questions around attention, arousal. It's an abbreviated mental test, and it's picks up on that new onset confusion as well. The 4AT does not require anybody to undergo any formal training to use it, which is brilliant. Yeah. It has high specificity and sensitivity, I can't say that particularly well, for detecting delirium. And in fact, there's been a number of studies indicating that it's actually very useful as a diagnostic tool to say that somebody's got delirium. So if you're scoring of 4 or more on a 4AT, then you would treat, and our pathway and the toolkit says treat as probable delirium. Okay. So the link to the 4AT is in our Dementia United webpage, is in our toolkit, so you can click on it. And also in our training resource, there is it's been developed by colleagues in Scotland. Emma will probably say a bit more than that, because I think it's Alistair McCulloch, is it? Yeah. And there is actually just a doctor in a hospital running through the 4AT and talking through the sorts of questions, because it doesn't need any formal training. And that's why it's been so useful to have as a tool for us all to use. It can be used in the community, it can be used in hospital settings. And although the NICE guidelines didn't originally include the 4AT as the tool to detect delirium, they included the confusion assessment method. That tool, the CAM, the confusion assessment method, required formal training, so nobody was using it. So they've actually revised the NICE guidelines now to include the 4AT, which Emma and I are very pleased about. But So I will put a link into the 4AT in the chat anyway, so you can have a quick look at it straight away,
Yeah.
those of you that are interested. But and the colleagues that have been doing the pilot work and using the toolkit, I think I found it very easy to use. I mean, I guess Jane and other teams might come in and say something about that. But yeah, it's great. It's something that you can use quite quickly, Emma. I am right, aren't I?
Yeah, I mean, mind you, we were talking this morning about sort of A&E data and saying, I don't know, if you're delayed by writing up like notes on the computer and it adds up to, you know, 1 minute, those add up to a lot. But also the person did sort of say, but if it's something really important in terms of an assessment, then, you know, obviously the benefits doing it outweigh the time factor. So yeah, it is, some of it you can do by observation, you know, the alertness level, and from sort of information from friends and family who would be with the patient, that is, are they different to how they are normally? And yeah, it has been well validated, and all this, the 4AT being recommended in NICE, it's sort of like a tag on, so it's kind of not as part of the original NICE guideline. There's like another web link, but hopefully nudge nudge Jane and other people, the 4AT will definitely be included in the next iteration, where you know, it can't not be, because I think it's what most places are sort of moving towards, or doing if they haven't already. And also, like, those sort of hard to assess groups, such as like stroke, there is that untestable element, and I guess that links into like learning disabilities. People might be misdiagnosed with a delirium when they don't actually have a delirium, but that's where knowing the person and what that person's baseline and what they're like normally is really, really important in you know, certain patient groups, certain groups of people. So thank you for that question, Melanie.
Yeah. Okay, thank you.
Are there any other questions?
I don't think anyone's asked us this,
Yeah.
but I think it's important for us to say, Emma, that all of the work that's on the Dementia United website is free for anybody to pinch with pride. So take it, use it, adapt it, as Jane found, it being part of the pilot, because we recognise that there's some great resources that you can be using to raise awareness about delirium, using to raise sort of start conversations. Certainly the lived experience resources are very powerful and can make a, you know, the audio recording, the film, you can just show them a couple of minutes in a meeting and get people talking about delirium. Same with the delirium leaflet as well. So please do feel free. And if you do use them and you want to feed back to us because they're not particularly suitable, I know that at the moment it's something we've been talking about a lot more, which is adapting them for people with a learning disability, Emma, haven't we? So quite a lot of the resource might need a bit of change, and we welcome that. You know, this is a community of practice where we grow and learn from each other. So thank you.
I'm just going to thank our first three speakers, Helen, Jane, Anam, and Jackie, and we've got a comfortable comfort break, so you have like 8 whole minutes to go and grab yourself a cup of tea, go to the toilet, etc., and I'll see you back here at 15:40 for the next bit. Okay.
Hello, Sam.
Hi, you okay?
I am going well.
Yeah, it's good. It's interesting.
It's interesting, isn't it? So hopefully people will come back shortly and we'll crack on with the next 3 sessions, which are brilliant. So I'm learning a lot.
Yeah. Well, I've left my camera on only for the simple fact if I turn it off, it doesn't always come back on. And I didn't want to. I've learnt from my past mistakes.
Yeah, no, sorry, Alison. Yeah.
So welcome back, folks, as you start joining us, hopefully. We'll restart at 3:40 for the second half. Thank you for those of you that have been with us so far. It's been really interesting. We will be sending out the slides, some training resources. I'm going to actually make a note to send out the 4AT itself because it's come up quite a bit, and also the research about it being a diagnostic tool to everybody, and other training resources. So do put your email in the chat if you haven't already, just to make sure that I can get the resources to you, and we'll keep in touch then with you if we, as we develop things, share the Delirium Zine workbook and so on, we can building on you all being part of our community of practice, developing and raising awareness about delirium. So, which is great. It's a nice way to end the afternoon, isn't it? Delirium conversations on a Friday. I appreciate not everybody's not in work tomorrow. Some people it's a working weekend or nights even. And Annam, thank you for joining us from, was it Birmingham? I think Annam said. Yeah.
That's okay. Thank you, Helen.
Right, Emma, shall I put up the slides to introduce the second half?
Yeah.
Assuming everybody's joined us again.
Yep. Welcome back, everybody. So we've got 3 more best practice examples around work in delirium across Greater Manchester. So the first speaker is Sam Turner, who's going to talk about a 7-minute education session in the hospital, an example from Wythenshawe, Trafford, Withington and Altrincham hospitals. Thank you very much, Sam.
Oops, sorry, Sam. I've just realised when I press present, it goes right back to the beginning. Won't be a minute. That's
okay.
Poor management by me.
No, I'm glad you're sharing. I appreciate it.
Thank you.
So, yeah, good afternoon. I'm a dementia specialist nurse for Wythenshawe, Trafford, Withington and Altrincham. And it was found through following audits and that that to start delivering, teaching and reviewing patients living with dementia, and most of the referrals we were getting were people that were developing a delirium and they had distressed behaviours. So it was noted that education around this area was limited, and even my own was limited, even coming from an acute respiratory background. And that knowing the difference between the person's diagnosis of dementia and that acute confusion, and the importance of knowing the difference and the person's baseline. And from coming from a previous really busy environment as a ward sister, it was noted that quick teaching around a subject was needed because staff were struggling to have breaks as it was, let alone attend teaching sessions. So I developed 7-minute teaching based really around the fact that if you say to somebody, have you got 5 minutes, they're not going to believe you. And if you say 10 minutes, people think, oh, I haven't got time for that. So 7 minutes, it's quick, and I'll show you an example in a sec of that. It's quick, it's around a specific area, and it's I've got a few different teaching sessions around people living with dementia, and the first one was started with the Getting to Know Me scheme of making sure that we had the Getting to Know Me cards in situ. I've got distress behaviours, mouthcare, nutrition, pain, and then we've got this delirium. So I start off by asking people on the ward, and I might have already organised with the ward manager that I'll come on between a certain time. So I might contact the ward manager and say, I can come whenever it's convenient for you guys. When do you think that time is convenient? And I'll base myself on the ward for about an hour, and I could deliver the session to one person, then 3 people could come to me. So yeah, so I'd start off asking the people, do they know what delirium is? Some people do know what it is, which is brilliant, but then obviously everybody's learning journey is different. So yeah, next slide, please. So obviously then if they don't know what it is or anything, I'll go on to discuss obviously the acute confusion and the difference between delirium and dementia. Yeah, next. Obviously then going on from what Emma was discussing previously of the different types of delirium, making sure that people are aware that people can go into hypoactive delirium, which is obviously harder to assess, and that is what we tend to worry that people are going to miss that, or they're having a sleep, and knowing if that's different for them in the day. We notice that hypoactive delirium is a higher rate of mortality, unfortunately. Yeah, next slide. This has just been put in only for the simple fact I do need to go out there and deliver this session a bit more. Have noticed increasing distress behaviours recently. Don't know if it is anything to do with the fact that we've changed to a Hive system and knowing where documentation is for certain areas. So this is new. And then following on from knowing where to, if the person is more confused and drowsy, then the 480 drops down, and then underneath that we'll develop the delirium bundle. So just giving prompts to make sure that people know to do their observations, a medical review, glucose, bloods, etc. Looking at constipation and that. So yeah, next slide, please. And so obviously think delirium and the prevention and management of that. So most people, when you think delirium, think an infection, but we go in to explain that there are different causes to delirium. A big issue that we do notice is pain. So we will then talk to the doctors with regards to the prescribing of pain relief for people living with dementia and the possible increase in delirium through not being prescribed pain relief. We do notice that people might be given, might say PRM medication, but that's not necessarily then given. So making sure the pain ads are used. And we just go through the different types of delirium and obviously use in the pictures me. Yep, next slide. So this was just developed from a number of incidents. These were people that were living with dementia that came into hospital and they had distressed periods of behaviour. Sorry for my spelling, I just saw that there. So we did notice a decline. There was an increase in April and we went back out and did some more teaching. We did notice that there was new staff that had started, so we ensured them, so we make sure that it's the revolving process of going out and reteaching. Yeah, next slide. That's just my details, and then I do offer time at the end of my 7-minute teaching for any questions that people want, and do let them know that we do offer 6 hours extra training with regards to people living with dementia, and delirium is part of that as well. Thank you.
Thanks, Sam. Is there anybody who has a pressing question now? Otherwise, we'll leave them for the end while people are having a think.
I was just going to say though, and Sam was trying to use her teaching as an example of showing us 7 minutes, and she's just done that in 7 minutes. So she's true. When she says she delivers them in 7 minutes, she delivers them in 7 minutes. So
yeah,
it's
that's the
impressive,
important
Sam.
bit. You do have to be honest.
So it's me next, isn't it?
It
So
is.
yeah, I'm going to talk about some work that we've done looking at the News 2, the early warning assessment score, the National Early Warning Score, and the 4AT, and how effective the News 2 is at picking up delirium and confusion. So if you can move to the next slide. So the News 2 is an aggregate early warning scoring system to identify acutely unwell patients, and the premise is that it's calculated from routinely collected physiological measurements. It was developed in 2012 by the Royal College of Physicians, and then it was updated to include new confusion and an iteration in 2017. And they added some further guidance around how to assess that based on sort of anecdotal feedback that people were finding it difficult to work out how to do that assessment. So if we could move on to the next slide. So the aim was to look at the sensitivity and the specificity of News 2 for non-alert states for a 4AT score of 4 or above, which would indicate a probable delirium. And this is work that we've written up and is in submission at the moment for publication. So if we could move on to the next slide. So all non-elective admissions aged 65 years and over to Salford Royal between the 1st of March in 2020 and up till March in 2022 were included. So we had a large number of records included, and the patients had to have in each episode at least one 4AT completed within 24 hours of the first attendance at hospital, and at least one News 2 score assessment within 4 hours either before or after that 4AT score. And all analyses were conducted using a statistical package, which is literally called R. There's nothing else, Helen. If you could move on. And so this shows that distribution of the time frame between 4AT. The 4AT being at that sort of time point 0, and you can see when news scores are done before, so up to kind of like either the news is done first or after, and you can see that the spread that most are the news scores are done before the 4AT and within that hour time frame. So if you move on to the next slide. So we included almost 14,000 consecutive admissions. 20% of those had a 4AT score of 4 or more, which is interesting just thinking of the non-English speaking data when you think about it. It's quite a different figure, isn't it? And 4.3% of admissions had a non-alert state recorded on their News 2. So on the News 2, there's a bit section called consciousness, and it's alert and then various non-alert states such as response to pain, response to voice, and then there is new confusion. And we found that the sensitivity of the News 2 for a non-alert assessment when the person's got a 4AT score of 4 or above was only 17%, but it's really specific. If somebody gets given new confusion on the News 2, then you can be 99% sure that they actually do have a delirium. We then just looked more specifically at that alertness question, which showed that 7% of admissions who had clearly abnormal arousal, 6% had mild sleepiness. And of those patients that were classed as clearly abnormal arousal, just over 70% of those had been classed as alert on the News 2. And of patients who had mild sleepiness on the 4AT, 88% of them were classed as alert. So if you could move on to the next slide. So this shows us if the 4AT score goes up, so 4 and above indicating a delirium with increasing sort of severity of delirium, because there seems to be a dose response relationship. You can see the scoring that people got on their News 2. So you could probably be pretty sure with a 4AT of 12 that their alertness level, that they've got some new confusion, and yet almost like getting up to sort of 60–70% of those have been scored as alert and haven't been given, you know, the light blue colour, which is new confusion. So that just kind of highlights sort of that disparity. So if you can move on to the next slide. And this shows, again, for the 480 alertness score, where it's clearly abnormal, mild sleepiness or normal. In normal, you know, fine, the majority of those are alert, but mild sleepiness and clearly abnormal on the 480, again, the vast majority being classed as alert on the News 2 score. So it just, again, it's just another sort of visual way of showing that disconnect in how the News 2 is being applied. So if we can move to the next slide. So how to sort of take this forward? I think what it's highlighted, and this was one organisation, it was people 65 years and over, but anecdotally, I don't think we're unusual. The News 2 has a low sensitivity but a high specificity for probable delirium based on the 480 scoring. And of those who were assessed as having clearly abnormal arousal on 480, more than 3/4 were assessed as being alert on the News 2. And so it shows, at least in this study, that the News 2 is just not reliable on its own for delirium detection. You need to do something in parallel. And I can't remember if I got a last slide or is that it? Yes. So recommendations. There's probably something maybe to go back, and I think there's going to be a further iteration of the News 2 about maybe it's because you can't have alert and new confusion, and technically you could be alert and have new confusion on the scoring system. Maybe it's about the presentation, because I know at Salford, like the levels of consciousness, it has alert and then all the other sections that still used to be there, like response to pain, response to voice, and then at the bottom new confusion. So maybe it's how it's presented to staff who are completing it. But I think kind of the gold standard would be that those older person or those at risk of delirium should have News 2 and a 480. And for older people, the Getting Right First Time report for geriatric medicine recommends something called the triple assessment, which would be clinical frailty score and 480 and the News 2 together. So yeah, that's me. Can come to an end. And just to acknowledge the other people I worked with, some colleagues, both in Salford and in Edinburgh, who helped complete this work. So thank you very much. And I'm going to skirt over questions for this particular moment and leave them till the end. So I'm going to introduce the last speaker in terms of our 6 best practice examples. And I'm introducing Kelly Smart from Thameside, who's going to talk about her work in pre-operative planning for risk of delirium. Thank you very much, Kelly.
Thanks, Emma. Good afternoon. So I'm here to showcase, I guess, some work that we've been planning for a while. Helen sat there smiling because you're really hopeful one day this will happen, actually, Helen, aren't you? No, it will happen. Unfortunately, due to clinical pressures, we haven't started this and we've been putting it off for some time, but I am definitely going to commence this piece of work very, very soon. So basically, within our trust, we're currently working on developing a delirium pathway, as we don't have one. And as a quick win, I felt that accessing pre-op patients may be a really good group of patients, a really good opportunity to focus on the prevention of delirium. So really, this is the only time, in my view, this seems to be the only time when we can actually prepare for an admission. We can think about what could happen, what we need to happen, what that person needs from us, and how we can prevent delirium. So I do have other agendas, as everyone does when they start these pieces of work. I've recently developed a local This Is Me document, which I'm really trying to embed across the community. And I am hoping to do some work around Playlist for Life. So all of those things combined, this felt like a really good opportunity for meaningful engagement with our carers and our patients within the Thameside community and Glossop. I felt that this would highlight a really person-centred approach to care. Potentially, this could reduce the length of stay in some of our patients, and there's a potential reduction in adverse incidents if we can prevent delirium. Next slide, please. So how it will work is I have a live list of patients, pre-operative patients with dementia, who will be attending our hospital at some point in the near future to have some form of surgery or surgical procedure. I will call every single one of those people. This is why the delay has happened. My team is currently 50% down on resource, and I desperately need some more resource, but it's not going to stop me. So I am going to personally call every single one of those people, the person with dementia or their carer, over a period of 3 months. I have, of course, recruited some assistance from digital champions, from our dementia champions, from our delirium champions, and volunteers. And this is going to be really, really useful to me, because if I'm trying to embed the playlist for life, for instance, the digital champions are going to be the people that are key players within this, as I cannot then go and visit everybody's house as well and try and assist them to develop a playlist for life using a laptop or a tablet. Obviously, the GM resources have saved everybody an awful lot of hard work. All those that have been involved have done all the hard work for us. So the GM delirium resources form a really big part of this piece of work. And my new This Is Me document obviously will be introduced to the person over the telephone initially. Next slide, please. So during this conversation, the big conversation, I intend to introduce myself. I'm going to introduce myself as an Admiral nurse and then explain what an Admiral nurse does, because I feel that puts you on good footing to start with. I'm not sure whether I need to explain. Helen, shall I explain what an Admiral nurse is?
Please do, because I don't know that everyone will know what an Admiral nurse is. Yeah.
Often we don't, and that's acceptable, isn't it? So an Admiral nurse is a specialist dementia nurse who supports carers and families of people living with dementia. So unusually for a nurse, our focus isn't the patient, it is the carer and the support network around that carer. So I will introduce myself as an Admiral nurse. I will explain what an Admiral nurse does. I'll explain the purpose of the call, which is basically to provide I've just looked at my, I thought I saw a spelling mistake. To provide an opportunity to prevent delirium, to educate the person around what delirium is and how they can help their loved one not to experience a delirium, to talk about the This Is Me document and the importance and significance of that document in providing care for their loved one. Obviously, the playlist for life is not for everybody, but those that do appreciate music and those that feel able to and willing to compile a list for playlist for life, I will discuss that with them. And I will then ask permission to send the This Is Me, the GM delirium, the short version of the leaflet. And obviously I will follow up once the person has had surgery. I will attend the ward and I will make sure that all the plans we've put in place to prevent delirium have stuck, have been maintained and followed through. So in effect, we will be creating a personalised care plan for each of these individuals. Firstly, with their partner, their loved one, their daughter, their son, whoever their carer is at home, looking at different ways they can prevent that person from experiencing a delirium by making sure they are well before surgery, they're eating and drinking, making sure that the This Is Me document is completed, any personal effects that person might need to bring with them to maintain orientation, and generally giving that person confidence in our trust, that we care, that we are wanting to do something different and we are hoping to prevent delirium. It also provides an opportunity to educate that carer about what delirium actually is. Some of these carers I am anticipating will tell me, oh, this has happened before. What you're telling me, I recognise. I feel like I've seen this before when he had surgery last time or when he was admitted last time. It's a really good opportunity for those types of conversations where the carer comes away feeling empowered, feeling they're doing even better at their job than they were in the first place, and that they can make a difference to probably a really anxious time for their loved one in hospital. So I will ask about previous surgical experiences and previous hospital admissions, and some of that may form part of something else. I might get some really good feedback, I might get some really bad feedback, but actually any feedback's going to be really useful to our trust to make sure that we're always improving and that we can continue to make a difference to patients. So ultimately, this exercise of giving someone a quick phone call covers a lot of things. It ticks a lot of boxes. But ultimately, it makes us look like we are doing a really good job and we really want to provide person-centred care. It will reduce the risk of developing delirium, hopefully. I can't measure that because I've not done it, but I'm hoping that will reduce the impact of delirium. And if that person does experience a delirium, it also means that we'll know what to do about it, because this person will have had their "this is me" document completed. The family members won't feel anxious because we will have already talked about it. They will have already received the resources and the information, so they will understand what delirium is, and actually might be the ones coming to the nursing staff and saying, oh, my husband's he's a bit confused today. My husband's experiencing this, and the Admiral nurse tells me that this could be delirium. Sometimes it does take that, doesn't it? It does take somebody else to recognise that. So overall, I think this is going to be a really effective piece of work for a number of reasons. Have I got another slide, Helen? I'm not sure if I have. And there's my contact details.
Thanks, Kelly. I've just posted in the chat a document that's around the peri-operative care of people with frailty. And there's a good section and reference to delirium in that, which kind of feeds into what Kelly's been talking about. It will work, Kelly, definitely. You know, all the evidence shows it should, so I'm wishing you well with the project.
Thank you.
So thank you to myself for speaking and to Kelly and Sam. Has anybody got any questions for any of us? Go on then, Helen. Chip in.
I've got a question for Kelly, because I wonder if people don't know what Playlist for Life is. And I know you've talked about it, and it's a fabulous resource for people if they don't know about it. Kelly, do you want to just mention it?
Yeah, of course. So Playlist for Life it is very, very basic, and it's free, just to kind of pitch that at people. You don't need to pay for anything. I think there is an opportunity to pay for training, but I don't think it's absolutely necessary. It's quite basic and straightforward. So it's tapping into people's experience with music, and as we know, most people on this call will realise the benefits of music for everybody, not just for those with dementia. It enables people it prompts people to pick a list of songs that are meaningful to the person with dementia, or I'm going to steer away from dementia, or the person without dementia who might want to create a playlist for life should they experience a hospital admission, or if they're in pain, if they're uncomfortable, if they're struggling to sleep. Playlist for Life can be the answer to all those prayers. So it'll prompt you there is a catalogue, and it prompts you to look at 30 years after they were born, I think it is, and every single song from every year is listed within that book. It might be that you can read them out and this person can say, oh yeah, I love that song, I remember when this happened. Or it might be that you play those songs to the person to see if there's any response. Sometimes you might get a tapping of the foot or a different facial expression, but actually songs are meaningful without people even realizing. It might be from a different era in their life. It might be a significant, wedding day. Some people mention assembly songs, which I still can't quite get my head around, but I know that, everybody's very different, aren't they? It literally lists every song, and there is a very quick prompt sheet to get you started. So it might be about, your birthday, any special anniversaries, any memories, of certain things. I can't remember exactly what's on the form, and this is on the back of my "This Is Me" document as well. And then basically they'll compile this list. In my area, if they're not able to do it themselves, the digital champions will assist them to get that either on a tablet, on an MP3 player, or in a link version. So it's all listed somewhere, and the link can be sent to our trust, so that we can use a tablet in the trust for them to play their Playlist for Life. So this can be beneficial for so many different reasons, that sometimes relatives will actually go out and buy maybe a handheld phone or a tablet because they can realise the potential of this. For instance, if the district nurses were going into their home to dress their legs and it was uncomfortable or they were anxious, if that person was able to access that device at home and play the music, that might really assist in calming that person down and preventing any further adverse incidents. Is that enough of a detail, Helen? Thank you.
Yeah, I've just been reading the book 1989 by Val McDermid, and at the end it's got like some songs from 1989, and then somebody reminded me that the Cure's album Disintegration came out in 1989, and that would be on my playlist for life.
It's interesting, isn't it? Because at the time, music's so important to you, and everyone now could probably name at least one song that's meaningful to them. But as time passes and more music is developed and released, we forget what songs they were until we hear it. And you can be driving along in the car, and the experience that you have from listening to a really good piece of music can absolutely change your mood. So, we can see the benefits in normal everyday life of that, can't we?
Yeah. Any other questions?
There's a question in the chat for Sam.
Yeah. Go ahead. And there's one, Claire Hunter's just put a hand up as well. Who's oh, Lorraine, do you want to go ahead with your question? Lorraine Abbott, does Sam do 7-minute lessons in the community is the question?
No, unfortunately, my 7 minutes, it is the hospital. Obviously, if you do want help with anything or anything, they can contact me. The contact details there, you can share them out, Helen. But I don't actually go out and do them, but I am willing to share stuff and that and train anybody up to deliver them.
Just imagine you bumping into a community team and saying, right, 7 minutes, go.
We are actually, there is a Trafford working group looking at delirium, and we're doing quite a lot of intense work, and we've been a really big focus on training, and we are meeting with Sam to talk through whether we try and use something like that might be of value in care homes, because we're about to do a pilot in care homes, folks. So let's hope by the time we have our next webinar that we might be involving Sam and colleagues from the care homes that we've been working with as part of a pilot, to let you know how valuable it was to do something that's very short and snappy with our care home colleagues.
And Claire, you patiently had your hand up, Claire Hunter.
It's all right, thank you, Emma. So it's just a quick one really. I'm probably going back to the initial presentation at the beginning. So it was alluded that there is a community toolkit which was tested across a number of localities within GM. I'm just trying to find out, in terms of detecting the delirium, whether it be through the 4AT tool, is there or was there a system that the community services were using at the time, and is that interoperable, I think, with acute services as well?
Yes, it's just to say that the community pathway very much mirrored what would happen to somebody in hospital. So the 480 is part of community pathways as well as hospital, and looking for causes very similar. I guess the kind of only difference is that element of risk assessment as to whether they can safely be cared for at home, but it also kind of taps into sort of emerging NHS care at home virtual ward models as well. So yes, and all the resources and sort of toolkit is on the in the Dementia United area. Yeah.
Fabulous, thank you.
In which case, I'm going to thank, including myself, our final 3 speakers, and I'm glad I have no questions. and our 3 earlier speakers. It's just really great to hear such enthusiastic examples of things that really making a difference, all the different pieces of work across Greater Manchester, and there'll be many more as well, I know, and that's illustrated by the fact we've got such good turnout, had such a good turnout for this. So thank you everybody for joining. I've got a couple of sort of final comments. Yeah, just to say thank you to all our presenters, everyone, for attending and for the discussion. And to have a think about what 3 things you would take away from the day. There'll be an evaluation form that will follow. Just make sure, a reminder, if you haven't done already, to put your email details in the chat so we can send you the recording link and the slides, and to share and promote the delirium resources and just continue raising awareness about delirium. We're going to arrange a further webinar in March 2023. So if anybody has any further new best practice examples, then get in touch with us, because I think it's all about kind of sharing things that are different, new, have worked. So thank you. Is there anything else, Helen?
No, just for me to thank you, Emma, and to thank all our attendees for today for joining us, and thank our speakers, because I know that there's a lot of work gone into all of this being pulled together. So do let us have your email addresses, and I will share the recording from today and the resources, and I look forward to seeing you at future webinars that we will host in and around World Delirium Awareness Day in March 2023.
Thank
Thank
you.
you. Thank you, everybody. I'll stop the recording.